Thank you. Good morning. Thank you for that kind introduction, and welcome. Relax. It's going to kind of be a fun and interesting day, and we're going to get a lot accomplished, and just sit back and enjoy it. It's a lot of new information. So how come we haven't heard about patient-centered medical home? I mean, my goodness. If physicians would read 2 articles a day, every day for a year, we'd be about 82 centuries behind in our reading. And that's problematic because there's so much information being thrown at us, and we're moving at such a fast rate of speed that bringing something new to our office is very, very difficult. Let me just review with you for a second the history of the patient-centered medical home. It was first introduced by pediatricians for special needs children in 1967. So it's not a new concept. The Institute of Medicine advocated for medical homes in 1996. The Future Family Medicine Project called for a personal medical home for all Americans in 2004, and the American College of Physicians called for advanced medical homes in 2006. So for those of us here who are family physicians, it's not a new concept. And for those of us who are pediatricians, it's a very old concept. So you have to ask yourselves, why aren't more of us already doing this? We have to believe here, since we're all primary care doctors, either internists, pediatricians, family physicians, and the overwhelming support staff that it takes to run our offices, why don't more people embrace this? Because primary care is foundational. The World Health Organization stated in 1978 that primary care is the key to attaining adequate health. And healthcare systems based on primary care have the following characteristics: better quality care, lower cost, less disparity, and better population health. But this is our office, and it's like going 600 miles an hour at 36,000 feet. We're moving at a rapid pace. We don't want to redesign the aircraft while it's in flight. That would be a very difficult task. So when we're asking you to turn your offices in one way or another into a patient-centered medical home, how do we do that without putting on the brakes? And that's where organizations like NCQA come in. You already have what it takes to become a patient-centered medical home. NCQA is more like the guide and the Wizard of Oz. They're just going to give you the information that you already have within you. But this is how we feel at the end of a busy day, and all of us have been there. Our patients are pushed. We're pushed. We're pushed for time. We need to take a chaotic atmosphere and environment and move it into more of a home sweet home, or a home sweet medical home. Sort of like this. Anybody recognize the house here? I know Dr. Fromer does. Right, this is Marcus Welby's house. Very, very good. 40 years ago, the ultimate patient-centered medical home. A place where we could go if we needed medical care. And we need to run our offices more like homes. I mean, if you went home, would you be happy if your home didn't open till 10 and then closed 2 hours for lunch and then opened again at 2 and closed at 4 and you couldn't get in? So access to care is a big component of the patient-centered medical home. So what is the patient-centered medical home and what is it about? It's about strong patient-physician relationships, engaging patients, new access to the physician, simple computer technology to track patient care against evidence-based standards, and supportive teams that help educate our patients about their diseases and stay committed to their care plan. See, the focus of the patient-centered medical home is managing care both inside the office and outside the office. And if you'll allow me just to read this slide to you. The focus is with the patient-physician relationship, and it must be strong. The patient must know who his physician is, and he must be able to see that physician when he thinks he needs to. The physician must be committed to treating the whole patient by coordinating other physicians, hospitals, ancillary providers, social service agencies, and the family. The patient must be informed about and actively engaged in his care, and the physician must help him get informed and be engaged. And that's just the Wikipedia definition. So there are 7 core features of the patient-centered medical home. The first and foremost is a personal physician. Identify with someone who you can call your own doctor. Physician-directed medical practice. It's a team, but every team, just like an orchestra, needs an orchestra leader. Whole person orientation. I'm not just going to take care of that right knee. I'm going to take care of the whole person, and if I can't do it, I want to direct that care elsewhere. Coordinated care and coordinated care quality and safety is first and foremost. That enhanced access. We need to make sure that our patients can get in to see us when they need to, and we need to be reimbursed for this. We're not going to do this for nothing. We're going to transform our offices into a better practice so that we can be more efficient, and hopefully, and it is coming to be, we can be recognized for that by various agencies and insurers and other avenues of payment so that we're going to get higher reimbursement for this. And we'll also be more efficient. And by increasing our efficiency, we will also do better financially for ourselves and our offices. So we've got that safety and quality, the whole person orientation, the physician-directed practice, payment for that added value, enhanced access to care, a personal physician, and a place where your care is coordinated and integrated, all ties together to give us that patient-centered medical home, which you've heard a lot about. Every patient needs a personal medical home where there's patient-centered care, a team approach to care, which is physician-directed, elimination of barriers to access, advanced information systems, including a standardized electronic healthcare record system, will not only make it easier to care for our patients, but will allow us to guide our patients through several years of care and through multiple consultations by coordinating everything into a neat and tidy package. Our offices need to be more functional. We need to make it such that patients are flowing through the office with less barriers. We need to identify that person as a whole person, an individual. And we're not doing this in an isolated manner. It needs to be done in a community context. What goes on in the community also affects our office and vice versa. We're not isolated entities. We need to focus on quality and safety. We need to have enhanced practice finance. And our offices need to define a basket of services that we can provide to our patients so that they know what they're getting when they come to see us. There are 4 elements of a patient-centered medical home. We need to better organize our practices. We need to embrace and adopt health information technology, improve our quality measures, and improve that patient experience. We want our patients to come back. Our patients are our friends. Patient-centered medical home will revitalize primary care. It provides a vision for the future practice of family medicine. It's a guide for office and redesign that promises better results for patients and for physicians. And it provides a path to fortify primary care and establish its value in our healthcare system. So why do we need NCQA? Why do we need the National Committee for Quality Assurance? And who are they? And Ms. Delage is going to talk about that in depth later. But it's a recognition process. See, the patient-centered medical home is an expanded role for us as primary care physicians in its comprehensiveness, in its follow-through, and in its population management. And doing more work must translate to getting more pay. But payers want an external validation that they are getting value when they pay more for a patient-centered medical home. Remember, it's a recognition, it's not a certification. You will be recognized as a patient-centered medical home of 1 to 3 levels, level 1, level 2, or level 3, based upon a score of up to 100 points, where your points are divided into subcategories, 9 categories, each of which have some elements that you have to pass and other elements that are optional. And the more elements that you pass, the higher that certification process is. And there are partial points given for your degrees of success. So it's not all just true false, like the old board questions we used to take. You get partial credit for answering some of these right. But it does require that the practice have written processes, and next, we need to audit those processes to see that they are being correctly followed. And the current NCQA criteria are technology weighted. That technology is very important to have in our practices. There have been groups that have achieved the patient-centered medical home recognition process without EHR. It is now increasingly more and more difficult to do that. So we need to embrace the technology. We need to embrace this concept. It is the wave of the future. So why do it at all? Because the patient-centered medical home creates a framework for change. It creates a common language for change, and it creates an opportunity for change. And that opportunity is before us, and we should embrace it. I want to introduce our speakers for this morning. Our first speaker, when I step down from this podium, will be Dr. Lynn Fromer. Dr. Fromer is a member of the board of TransferMed. He acts as a consultant to TransferMed in the area of clinical integration, the Center of Excellence, Quality Improvement in Chronic Diseases, coupled with successful practice transformation to the patient-centered medical home and accountable care organizations. He is a fellow of the American Academy of Family Physicians and a diplomate of both the American Board of Family Practice and the National Board of Medical Examiners. He's been in private practice in Santa Monica, California with the Prairie Medical Group for over 28 years. Dr. Fromer has served on the group's board of directors and has been its managing director as well as its chief financial officer. He's past president of the California Academy of Family Physicians, and for the last 10 years has served as a member and chairman of the American Academy of Family Physicians Commission on Healthcare Services. He's been a member of the AAFP Commission on Quality and Practice, a lot of other boards, but mainly he's an excellent speaker and one heck of a great guy. Our next speaker after Dr. Fromer is going to be Carol Delage. Carol Delage is president of the Tashiti Corporation, a consulting company specializing in accreditation and regulatory compliance. Her national client base includes managed care, managed behavioral health, disease management, and wellness organizations. Carol's expertise includes applying quality improvement principles and practices to daily operations to improve performance and meet requirements. It's a tough job, Carol. Ms. Delage received a Bachelor of Arts degree in nursing from St. Catherine University in St. Paul, Minnesota, and a Master of Science in nursing from the University of Minnesota. For the last decade, actually over that, she's been an administrative surveyor for NCQA, the National Committee for Quality Assurance, an accreditation organization that accredits health care plans and a variety of other types of organizations. Thank you for coming. Your day is going to be very enjoyable. I would now like to introduce Dr. Lynn Fromer.